Hi everyone, my name is Yuz Yusof. I'm reporting for Room Now. I'm reporting from Leeds, United Kingdom, and have been joining the conference through as a virtual delegate. Today is the last day of ACR, and there have been plenty of data that have been presented. And one of them that caught my eyes is a late-breaking abstract. So the number is L08. So I'm privileged to be joined by Dr. Christopher Podgorski from Washington, who presented the abstract. Hi, Chris. Hi, Chris.
Hi, Yuz. Thanks for having me.
Yeah, you're welcome. The abstract is about the early experience on using Evusheld in patient with rheumatic disease. Could you tell us the rationale behind the studies and what were the objectives?
Sure thing. Well, ever since the FDA gave authorization under emergency use for tixagevimab, silgavimab, Tixil or Evusheld, its use as a pre-exposure prophylaxis for rheumatologic patients has yet to really be seen as far as the long-term efficacy. And so our goal was to bring to light at least 6 months of continuous data to really help show meaningful use in our rheumatologic patients.
Very good. Would you like to tell us what were your methods, study design, and the key summary of your outcomes?
Sure. Well, this was a longitudinal study of all variety of rheumatic diseases in our clinic at Washington University in St. Louis. And longitudinal in the sense that we followed forward 157 patients who had received Evusheld, stretching from initial administration in January of 22 all the way through August of 22. And we're monitoring for breakthrough COVID infection rates despite dosing with the prophylaxis. And this was all confirmed with retrospective chart review as well. And the outcomes and what we saw is that with the 157 administrations that we patients that we had administered the drug with, is that we saw 24 breakthrough cases, so about 15% breakthrough, which as our real world experience and 6-month data had yet to really been borne out across other groups. And so wanted to, or appreciated having the opportunity to present this at ACR.
Oh, that's fantastic. Can I just clarify your cohort? How many proportions of them were on B-cell depletion therapy? And, for instance, like myself in the United Kingdom, unfortunately, our government is not funding the Evusheld despite it's been approved by the European agencies since March. So I think you just want to know a little bit, for us, what sort of in the population of patients that you gave the Evusheld?
Sure. Well, of the 157 patients that eventually got Evusheld, 37% or 59 of those patients were on rituximab. So a fair number were actually on alternative therapies as well. At our institution, the initial allocation being in selected numbers was initially prioritized to the B-cell depleting therapies, but was eventually opened up to all of our patients. And yeah.
And in terms of all of the patients, do they have to be like not mounting antibody response, or you can actually give people who were on immunosuppressive therapies?
There were many people that were just on immunosuppressive therapies. There were a number of folks on kind of combination therapies as well, steroids plus many other agents that it raises the relative level of immunosuppression in itself. We felt warranted Evusheld. as additional coverage.
So the data looks good. It's only 15% breakthrough infection, and I believe is it 1 or 2 severe COVID outcomes that you've had in your cohort?
The vast majority of the 24 breakthrough cases were mild to moderate symptoms. Yes. We had no deaths, 2 hospitalizations. Notable trends with those 2 hospitalizations: both patients were receiving rituximab. Both had additional comorbidities. One patient underlying RA, but additional COPD. Second hospitalization was ANCA vasculitis with COPD as well.
So this is really encouraging. I think there's probably just one more last questions. There have been concerns about because this study was done up till August, and variants are changing as well. So what's your view on that? And have you got any more plans to follow this patient up, or even like repeat dosing, treatment with Evusheld to see whether it's effective on the subsequent variants? Never ending.
It's a very good question and a big problem for us. I think that the subsequent dosing is a worthwhile point to look into as well, as opposed to the current recommendations that recommend 6-month interval dosing with Evusheld. We had seen from our data that after about 3 months was the average rate of breakthrough. So whether dealing with scheduling, but also you mentioned, evolving subvariants and possible escape from Evusheld coverage. And I think it's important to recognize that moving target and maybe something that we need to talk about a updated monoclonal therapy, much like we're updating with our vaccines. If we can update our prophylactics as well, would be additional layers of protection for our patients.
Yep, so fantastic. So thank you so much for your quick summary of your work, and I hope you enjoy our discussion today. And please, tune in to Room Now either through YouTube, LinkedIn, or tweet for more coverage from ACR. Okay, bye bye. Thank you.
Thank you so much for having me.